Well, good afternoon, everybody. Welcome to the critical care lecture. My name is Alamiri, and although I've been assigned this lecture, but I think it's very interesting, and I'll be talking about adrenal insufficiency in the critical ill patients. I have no disclosures. John F. Kennedy, if you guys don't know, he was actually diagnosed with a form of adrenal insufficiency and is believed to be secondary to his exogenous use of glucocorticoids because of his Crohn's disease. Maybe he's one of the most famous people, if not the most of them all, to have this form of disease. So an outline of my lecture, I'll be talking a little bit about the physiology, also a little bit about the types, just a brief talk about the clinical manifestations, but I'll be focusing more about how to measure or what to measure the cortisol level. Should we treat, should we not treat? And there is any role of the vasopressors as well, and what does the future hold for diagnosis of this entity. This slide can summarize the physiology. Whatever happens either from the stress or any form of insult, or to all the normal release of the CRH from the circadian rhythm goes to the hypothalamus, CRH is being released, go to the anterior pituitary gland, ACTH get released to the adrenal gland and my beautiful organ, the kidneys, and that also then release the cortisol, which has many functions as we know. The heart can increase the heart rate, increase contractility, stroke volume as well. Can also have effect on the fat cells, which then the fatty acid will be mobilized. Liver has effect on the gluconeogenesis and the deamination of the protein that will aid in this gluconeogenesis. Same thing happens with the muscles, but also most importantly with the immune system, which can be altered. The steroids, what can do is stimulation of the anti-inflammatory by increasing the cytokine production and also inhibition of the pro-inflammatory cytokines. As we all know, this is just a summary of, we're not going to go into details about it, but I just want to show you what hormones will be released from the adrenal gland, going from the zona glomerulosa, fasciculata, and the reticularis. The deeper we go, the sweeter it gets. We go from salt, aldosterone, go from sugar, cortisol, to the sex hormones. For the purpose of our lecture, we're only going to be focused on the cortisol. Although some might debate that the adrenal insufficiency might have, especially in acute, might have also some form of aldosterone problem, but for now we're just going to concentrate on the cortisol. So basically what this slide shows is just the circadian rhythm of the steroid and ACTH release. And as we can all see, that it basically get released mostly in the morning, with the highest in the 8 o'clock. Highest at a.m. in the morning, being a level of 20 micro per deciliter, and lowest at midnight. And also we can see that there's effect of the light as well. We need just to keep in mind that our patient in the ICU, they're on and off light in the room, might also have an effect. And also, this is the normal level, 15 to 25, but in the stress, usually it's different. It can go as high as 150, not as to 300, but that's the highest number that we can see, or we can see even higher. But also the levels range from 40 to 60 microgram per deciliter when we measure it. But also in the stress, we lose this circadian rhythm as well. So that becomes also a problem. But if we want to look into more, and I failed to mention, the T half of the cortisol is only 60 to 90 minutes. If we will look into the physiology as well, when the steroids are being circulated in the system, we need to remember that 90% of it is bound to either cortisol-bounding protein or albumin, but to less extent to the albumin, and only 10% is free and biologically active. Now it get converted from the inactive form, the cortisone, to the cortisol via the 11-beta hydroxysteroid dehydrogenase. And the question to the fellows, do we know what medication can inhibit this that we use in the ICU all the time? Etomidate, that's right. Well, just keep in mind when we look at this think we should stick with raspy for now. All right. Well, just keep in mind that this is a very highly aerobic, auto-demanding process. So when we have our hypoxic patients or anaerobic phase, this also will get altered. So what happens in adrenal insufficiency? What kind of problems we start getting? So it's more than one thing that happens, and the whole hepatopituitary adrenal axis gets disturbed. So there's a problem with the ACTH levels. We have a problem with the cortisol levels as well. We'll also have loss, as we said earlier, for the diurnal variation. The cortisol initially, but maybe later on will be different, but it will be high. The cytokine release, as we mentioned, will also get affected by the cortisol level. And some of them will be pro-inflammatory, some of them will be anti-inflammatory as well. And also the albumin and the CBG will be severely reduced. As we know, this is a hepatic production, but also because of the elastase-induced cleavage and the liver, this will be reduced as well. So we're going to have more of the free cortisol level. We're going to be talking about it later as well, later on. Volume distribution will be, most of our patients will have the third spacing as well. But if we want to just summarize all these problems, we can look at just any form of stress. The most common thing that we deal with usually is infection or sepsis. So what happens? It affects the hypothalamus, so it starts affecting the CRH release, the corticotropin, and then also the cortisol, as we all know, will have an inhibition feedback to the pituitary and also to the hypothalamus. But what happens when we have this inflammation? We have these infections. So if you look at the macrophages here, we'll start releasing the interleukin-1 receptor antagonist, and we'll also then affect the CRH receptors. We're also going to have a negative feedback. So overall, the cortisol production should be reduced in patients with infections. So that might cause as well something that we call the macrophage migration inhibitory factor that has been studied and published as well, like in 2005. So a patient may be not just adrenal insufficient, but they might have a form of contemporary adrenal dysfunction more than anything. So if we want to talk about types of adrenal insufficiency, we have three major types. We're not going to go into details about each one of them, but just honorable mentions. And the first one we should be thinking about primary chronic. What do I mean by that? It's either autoimmune diseases. We have HIV by itself, any form of malignancy, TB, DIC, drugs. Yes, antifungal is one of them as well. And CMV, or fungal infection. Also, the antiphospholipid syndrome. And we have another type, which is the secondary chronic. And any form of hypopituitarism, any cause of hypopituitarism that ranges from surgery, radiation, the empty-cell syndrome as well, Sheehan syndrome, craniopharyngioma as well, and of course exogenous glucocorticoids, and sarcoidosis. And this is just, I'm sorry, I should have said drugs, but I got missed, but these are just some of the drugs that can cause the form of adrenal insufficiency. Of course, the steroids, the antifungal, etomidate, metronidazole as well, which we'll talk about later, and phenytoin as well. If we want to look at the main difference between both acute and chronic, regardless if it's primary or secondary, if we look at the chronic, it's a gland disease itself. So it's not just the cortisol being affected, it's the whole production of the adrenal gland, so including the aldosterone. So when this happens, we're going to have mineralocorticoid deficiency, and this can cause hyperkalemia and hyponatremia. But someone say, well, it also happens with acute adrenal insufficiency. True, but in a different mechanism. So if we look at the hyponatremia from the aldosterone deficiency or the mineralocorticoid deficiency, we're going to start losing our water reabsorption. So we're going to have more of the patients who are having hypovolemic, hyponatremic, but when we start having the acute phase, and it's most of the cortisol, we're going to have the hyponatremia most likely from the volume redistribution. And also with acute, we're going to have a high ACTH level. We do not measure it for diagnosis. It's mostly been done in the studies. But in chronic, it's usually low. Also, we need to keep in mind that cortisol response is kind of different or inadequate, and depends on the severity of the illness. If it's very severe, it might be very high, or it might be very low. We still don't know yet. But given this variety of the response to the cortisol, the sign and symptoms becomes different. But just to look at it, it ranges from hemodynamic instability, goes from fever, inflammation without any obvious source, alternative status or neurological manifestation, nausea, vomiting, diarrhea, hypoglycemia or normal glycemia as well, eosinophilia, we don't see that very often, sometimes we can miss it, or even hyponatremia and hyperkalemia. Now for us in the ICU, we receive our patients from the ER. Most of them are fluid resuscitated, and most of them have their electrolytes replaced. So we might miss the first two. But let me ask you this, how many patients you see in the ICU have normal glucose, they now become hyperglycemic despite being severely affected? And how many patients they have fever, negative blood cultures, and it's always either drug or neurological. It's just a thought. So will all patients with adrenal insufficiency have the same values? Will all have the same numbers when we try to diagnose this? Or do we have any standardized method in measuring the cortisol level? Well, before going to that, we need to know what factors affect the cortisol level. This is just to summarize it. So it varies initially during the illness, as we said, and there's a decreased response to the ACTH. The albumin and cortisol binding globulin will be low, so that might affect the measurement of it. Hormone levels, drugs, and also with like any stress or any acute stress, I should say, they're going to be having any reduced metabolism with decreased excretion and breakdown, increase the receptor resistance, and a form of inflammation. So in 2004 came this article about measuring the free serum cortisol in the critically ill patient, and what they used basically, they used a 250 microgram IV cocentrogen stimulating test, the CST test. And this is just to show you that the baseline, they had two groups. Group 1, patients with hypoalbuminemia less than 2.5. Group 2 with normal albumin level. And they compared it with healthy volunteers. And we look at the baseline of the total cortisol. So there was a big difference between all three groups compared to the free cortisol, which is just the healthy individual, the healthy volunteers were low compared to being high in both. So, and if we were, again, just to look, the serum albumin for both groups, it was an average 1.7 in group 1, the hypoalbuminemia, and it was 2.6 or more in the normal albumin. So what are we looking at? Basically, if we want to compare the patients who had hypoalbuminemia, the total free cortisol was lower compared to the patients with normal albumin, and that was statistically significant. But when they went on and they measured the free cortisol, there was not much different. They were both high compared to baseline, or what is considered normal. So how do they do this test? What is this test? It's basically something called the sandwich assay. And basically what they put, it's a microvial where they put the patient's serum in it. And as we know, the cortisol is being bound to the CBG or the albumin. And there's also this semi-permeable membrane. On the other side, they put on it the radioimmune assay isotope. And what happens is that the RIA or the isotope drag the cortisol away from the albumin, and they measure it. Now, we do not have this here at Henry Ford. And it takes days for it to come back. So it's not like something we can have it within one day. And God knows if our patients have a day or so. So what does this test mean, or what's the difference between the total and free cortisol? Although albumin might give us false positive. So we might think the patients have adrenal insufficiency, but they're actually not. And we know that a lot of our patients are hypoalbuminemic. And we also know that a lot of studies have showed that low albumin patients usually do poor. So all we can say about the measuring of free cortisol, we still need more studies in that sense. High versus low, there's a lot of debate. Endocrinologists will talk about it all the time. But thankfully, we have people that will help us to guide us, which is back in 2016, the Surviving Sepsis campaign. gave us a guideline about it. As we said earlier, it's a controversial thing. And they're recommending let's not test for it. Forget it. They don't want us to test for the cortisol level. So, but you feel you want to test for it. You want to test for cortisol. You just want to do it. I don't know. I just want to do it. Give me something. For the non-believers out there, they said, okay, just go ahead and use the high dose. So all the studies from here on, I'm going to be using the high dose of 250 microgram of the CST test. And we need to remember that we need to have the measurement at baseline, 30 minutes and 60 minutes after giving the CST. So also the response for the CST is different between primary and secondary causes for the chronic. And this has been studies in different patients, different endocrine literature. But all these literature were based on patients who were not sick, who were normal subjects. So, but what about our patients, the patients that we see in our ICU? What are the numbers? Do we have any study that support that? All these studies back in the mid-80s to the mid-90s as well look at the cortisol level for patients who are believed to be having adrenal insufficiency. And if you look at the numbers, they were ranging between 10 to 22. So it was safe to assume at the time that anything less than 20, most likely the patient had a form of adrenal insufficiency. In 2006, Dr. Anand published this study, which is diagnosis of adrenal insufficiency in severe sepsis and septic shock. And they basically looked at two different cohort studies. And here, what they did, the first study, you actually look at a total of 61 and 41 patients, a total of 101 patients. And they had a control group, which was a total of 44 ICU patients without sepsis and 32 healthy volunteers. And how did they test? They did the CST test, and they did the MTE test, the methylpron test, which is we do not do on a regular basis because we all know it can cause severe hypoglycemia. So it's mostly done in the studies. And this is what they measured: ACTH, cortisol, the protein or the albumin, and 11-beta deoxycortisol. So when they did the MTE test and they confirmed the diagnosis of form of adrenal insufficiency, they compared between the two cohort studies, which were positive results, compared to the healthy individual who did not have any adrenal insufficiency. But then we want to look at the cortisol level for those positive patients, based on the MTA test. They compared to the CST test. You can see that, as you said earlier, everybody assumed it was less than 20. But when they look at the CST test, for anyone who had less than 15, only 22 patients had those numbers. And also the healthy individual had less cortisol level than 15. So maybe less than 20 can be anything, can be normal as well, right? But what they also found that the delta cortisol, what that means is the response of the cortisol to the test should go high or it does not respond. For the delta cortisol, less than 9, 17 patients did not respond. So what I mean by non-responders from now on means that it was a positive test, and none of the healthy individuals had that. They all had more than 9. From that study, they also found that 60% patients had adrenal insufficiency. So, but they want to give us specific numbers. So the best predictive values based on this study was the total cortisol less than 10. But most importantly, the delta cortisol less than 9. And they also found these two finding that most of the patients who have a form of adrenal insufficiency had vasopressor dependence, and they have positive blood culture, specifically gram-negative. But Dr. Anand again went back and looked at, or want to confirm this, that I actually looked at the mortality of having these numbers. So in 2008, this is also a prospective cohort study. They looked at a total of almost 190, it's 189 patients with septic shock and severe sepsis. They also did the 250 microgram CST test, but they were and here they compared the total cortisol with the delta cortisol, and they looked at the 28-day mortality, and this is what they found. They divided patients into 3 categories: who did good, intermediate, and poor. And if you look at the poor, patients who had despite having high T cortisol, what was considered high or normal, their delta less than 9 had a mortality of 82%. Compared to the intermediate, some of them had high or low. So the question is, maybe the patient had enough cortisol, but is there any form of resistance? Is there any form of they're not going to mount, or they cannot respond anymore to the cortisol? Is it like an end-organ problem? But that was the finding of the study. Then, okay, now we did the study. Now we measured for the adrenal. We did the CST test. We measured the cortisol, the delta. The patient now has a form of adrenal insufficiency. Now we know that. But the question is it adrenal disease, or is it immunological imbalance? Is it a problem with the system itself? And of course, what if you find it? Do you treat or you do not treat? In the mid-90s, Dr. Roger Bone developed this paradigm of sepsis. And what we're looking at, basically, when you have any form of insult, you're going to have both local anti-inflammatory and pro-inflammatory response that will cause anything from the source, the CARs, basically, which is just a compensatory anti-inflammatory cytokines being released, ranging from interleukin 4, 10, 13, 11, also anti-TNF, or you might have a mix of both. But which one takes over? And when you have this disturbance, this is when you might have the chaos theory. Cardiovascular compromise, you might have shock, hemostasis, and you might have apoptosis, the cell death, any organ dysfunction, or eventually you might have just suppression of the immune system when the CARS takes over. When we look at our ICU patients, we also ask ourselves, where do they stand, or where do they lie in the Sterling curve? Are they hyperdynamic? Are they hypodynamic? And do they need any pressure? Do they need any volume? But do we ask ourselves the same thing when we look at inflammation? As we know, early in the disease or any form of inflammatory response, we have this increased surge of anti-inflammatory that we all know has been shown to increase mortality. And as the disease progresses, or maybe the pro-inflammatory, as the disease progresses, maybe the anti-inflammatory start taking over, and the patient become immunosuppressed, and this has also been shown to have late mortality. But how do we get the patient to that sweet spot when we try to keep them away from both, not having the surge and pro-inflammatory versus anti-inflammatory? I'm pretty sure that we all by now memorize this by heart. We know the potency of all the steroids, and we mostly use the hydrocortisone. But the reason I put it is not just to show you the number, but also to remind you what medications they used when they studied all these studies back in the day. So if you look at all the studies before the 90s, they were giving a lot of steroids, all these dosage, and what was equivalent of more than 300 to 500 sometimes milligram to a gram for these patients. So they were actually, and as we said earlier, the normal levels, 15 to 25, and stress, it's 150 to 300. So we're giving more than that. But in the mid-90s, they started giving way low, definitely less than 300. Fast forward to the 21st century, we have now this study published in 2002. Again, Dr. Anam was looking at effective the treatment low dose of hydrocortisone and 4NF of the fluorocortisone on mortality in patients with septic shock. It was double-blinded, randomized, it's multicentral. They give hydrocortisone and the 4NF. They looked at 28-day mortality. The dosage for the hydrocortisone was 50 milligram Q6, and the 4NF was 50 microgram Q-day. On the slide, the picture on your left, you look at the patients who were non-responsive, meaning they had positive tests, they had a form of adrenal insufficiency, and we'll look at the probability of their survival. And as we see through this Kaplan-Meier curve, there's a dissociation that happens between the steroids and the placebo. And the probability of survival drops with the placebo compared to the steroids. And when we look at the responders who actually had negative study, there was not much difference. And this is actually what's statistically significant. And we look at the overall patients, also for the probability of survival, also there was dissociation. and it's also statistically significant. But they didn't just look into that. They also looked at the continuation of when they were able to take off pressors. Again, on the left, the patients who were non-responders or had a positive test, as we can see, they start taking off, and we're taking off early for the patient who received steroids compared to the patient who were not receiving steroids. And this is just to show the cumulative effect for all patients who were starting on the steroids. As the patient was starting steroids, they have less cumulative effect or less need for pressors during their stay compared to the patient who did not receive steroids. And also, that was statistically significant. But like any other study, we like to replicate it. We like to find the result in other studies. Cortis study in 2008, hydrocortisone therapy for patients with septic shock. So of the 500 patients, divided into two, almost half of both, and it was controlled, randomized, placebo-controlled and randomized. But there's nothing more to say except looking at the graph. They didn't see much between the placebo and the hydrocortisone compared to both patients who were actually positive test or negative test. Also, all the patients didn't have any mortality benefit. So I have two studies, two different results. What does this mean? The devil's in the details. So if you look at the Anand studies, actually they started treating way early compared to the Cortico study. They waited 3 days with open label. You can use it whenever you want in the Cortico study. Floronef. You can't ignore the fact that Anand did use Floronef. It does have some form of minocorticoid. It does have actually a high minocorticoid activity. Tapering of the steroids were done in the Cortico, were not done in the Anand. Medical patients were more in the Anand compared to the Cortico study, and they were more surgical in the Cortico than the Anand. And the mortality for the placebo patient in the Anand was 60%, compared only to 30-40% in the Cortico study. Just FYI as well, when they did a sub-analysis for the mortality in the Cortico study, for patients with high mortality, not just lower mortality, they did find a form of mortality significance as well as using steroids.
How did they talk about why
No, that was just thrown out there. They didn't say why they used the 72 hours. So, is timing is the answer? We don't know, but there was the study that early administration of steroids after the advent of septic shock. So we had to develop septic shock first and see exactly what's going to happen, and this is what they found. So this is for the survival, late versus early, and we can see also early phase started to take off compared to the late, and also the need for pressors was statistically significant when you start early compared to late. Now, also what they looked at, although they don't look at all those numbers, but they tried to compare the effective floor high Apache score, not just for the septic shock, and the early and late initiation for hydrocortisone. What they found is patients who had high Apache score, the early initiation of steroids increased the survival from 19 to 41. That was statistically significant. And also patients who had low Apache, they didn't have survival benefit, 55 to 83%. We all know this. We're not a fan of vasopressin in the MICU. Our SICU colleagues might beg the difference. But this study was showed there was no mortality benefit. As we all know, we looked at the 28-day mortality, and they found that more severe septic patient defined by needing more than 50 microgram of levo or norepinephrine compared to the less or severe, 5 to 15 mics of norepi. For the severe sepsis, no statistical significance in 28 or even 90-day mortality. But for the 5-15, it's out there for debate because they were less sick. But the conclusion of the study was no significant mortality reduction rate with vasopressin. Why am I bringing this up? So, and come up with this study. In 2009, interaction of vasopressin infusion corticosteroid treatment and mortality of septic shock. What does have vasopressin have to do anything with cortisol? That doesn't make sense. Well, on the contrary, on physiology, if you look at the arginine vasopressin release, it actually stimulates the cortisol, and the cortisol inhibits the arginine vasopressin release. So they're actually interaction, and the ABP, as we said, stimulates the cortisol. So maybe we need it, maybe not. And the cortisol inhibits the ABP. So what was the study? It was actually a post-hoc sub-study. What does that mean? Basically, it consists of looking at the data after the study has been concluded for patterns that were not specified earlier in the study. It was a multicentral. It was randomized controlled as well. And this is also the controls was vasopressin versus norepi and septic shock. We conclude 27 ICUs in Canada, USA, and Australia. And a total of 779 patients who had septic shock requiring at least 5 mics of norepi for 6 hours. It was an open label, meaning that patients were randomized, blinded to vasopressin, and that was the dose 0.01, 0.03 units per minute, or levo, 5 to 15 infusion, added to an open label vasopressin. So you can choose whatever you want. And the corticosteroids were given according to the clinical judgment. There was no criteria for that. And they looked at the 28-day mortality rate. And this is what they found. Significant interaction between vasopressin infusion and the steroids. So what does that mean? Patients who had steroids, levo, and vasopressin, the mortality was 35.9%. Levo alone, 44.7%. That was statistically significant. But what about patients who did not have steroids? Unlike the New England Journal of Medicine study, not just showed there's no mortality benefit, but actually showed that patients who were on vasopressin alone did worse compared to levo, 33% to 21% respectively, and that was also statistically significant. So, for the patients who had vasopressin infusion, what they found as well, the corticosteroids did increase the plasma vasopressin by 33% at the 6-hour period, initial period, 67% at 24 hours. So that's a lot of increase of the vasopressin compared with patients who did not receive the corticosteroids. Nothing makes sense. I hope you're not confused, but I can assure you this is not alien science. But just to take a look back at what we talked, what would people, smart people, actually who've been studying this their whole life, want us to know, like this guy. So the diagnosis is imperfect. Diagnosis is imperfect. Cortisol levels can be variable. Variability in ACTH also, we need to think about it as well. Then how to interpret the CST result as well. And is it a true adrenal disease, or is it just a cortisol imbalance? Timing, when do we need to start the steroids? Role of vasopressin. Don't think about it as just a suppressor. Think about it as from physiological standpoint. Do we need to add it or not? And of course, the resuscitation, are they depleted or not? Are they adequately depleted? And are they still vasopressor dependent? And remember that this is an inflammatory heterogeneity disease, meaning that we have hyperinflammation versus anti-inflammation. Which one will win? That was me after Dr. was giving me his private lecture. I was so happy, but I don't understand anything. I wanted to tell me either yes or no. That's all I need to know. And then he told me, look at this study. The corticosteroid treatment for severe sepsis and septic shock in adults. It's a meta-analysis. And I looked at all the studies back from the 70s to the late 2000s. And this is what they found. On the left side, favorable the use of steroids. But also last year, the Cochrane collaboration found similar results with this funnel plot log that did actually favor the use of corticosteroids in critically ill patients with a form of adrenal insufficiency. And now, given this imperfection of the diagnosis, what does the future hold? Where do we stand, basically? So, it's more than one thing that we need to look into as well. it's given that there's too much uncertainty going on. Maybe the way that we need to go is actually precision medicine. We need to look into the genome. We need to look at the RNAs. We look at the proteins. We need to look also at the metabolism of the whole spectrum, ranging from sugars, ranging from amino acid, lipids. As we all know, cortisol is needed for the. Cholesterol is needed for the cortisol synthesis, but I didn't find any study that said that they measure the cholesterol level as well, or the free cholesterol. So these may be the way to go as well. And take any questions from here. Thank you.